data supporting a second maintenance platform really emerged with the use of PARP inhibitors in these actual 4 clinical trials that led to 3 FDA approvals in this space. And we've seen how PARPs have moved from advanced recurrent ovarian cancer to second-line maintenance to first-line maintenance, with the impact of these this class of drugs seeming to increase the further we move them up into a patient's treatment regimen. So these studies demonstrated the benefit of the PARP inhibitors, but also, again, as we've highlighted, differential benefit among biomarker-defined groups. The progression-free survival in the germline BRCA groups ranged, as you can see on the slide, from 11.2 to 15.5 months. And this translated into a 70 to 77% reduction in risk of progression. So, and the progression-free survival, even in the non-gBRCA groups, were also significantly improved. But as we mentioned, just not to the extent in the germline or the HRD-defined treatment groups. So the randomized phase 3 NOVA trial assessed niraparib as maintenance therapy for patients with platinum-sensitive ovarian cancer who were in response to their recurrence therapy, their recurrence platinum therapy. And the trial actually consisted of 2 independent cohorts based on germline BRCA status. So there was a gBRCA cohort and there was a non-gBRCA, and then within each of those, they were randomized 2 to 1. To niraparib versus placebo. And this figure shows the Kaplan-Meier plots of the progression-free survival in the germline BRCA cohort. And again, these curves showed an early and sustained divergence with a median progression-free survival of 21 months in the niraparib group versus 5.5 months in the placebo group, with 62% of women progression-free at a year versus 16% in the placebo group, and at 18 months, 50% versus 16%. And the data also demonstrated that niraparib increased PFS regardless of whether the patients had a BRCA mutation when compared to placebo. The bottom curve actually describes so I'll just highlight your attention. This bottom curve highlights the non-gBRCA cohort with a PFS of 9.3 versus 3.9, and then within that group, those who were HRD positive, again, a biomarker demonstrating probably more efficacy in that group, 12.9 versus 3.8 months survival. So for those, I won't go into all the details of this slide, but for those taking niraparib, grade 3 or 4 adverse events that were commonly reported, as most of us have gotten pretty comfortable with now, is the thrombocytopenia at 34%, anemia at 25%, and then neutropenia at 19%. And highlighted here, 66% of the patients had treatment emergent adverse events that led to a dose reduction, with a resulting almost 15% discontinuing treatment because of those adverse events. So the phase 3 aerial trial affirmed the results of the NOVA trial, as well as SOLO 2, which we haven't had time to highlight, which also has some fairly exciting survival results coming out. But as far as aerial 3, the eligibility criteria were similar to that described in NOVA. But specifically to this trial, women were allowed to enroll if they had bulky residual disease. And so in contrast to the NOVA trial, the responders in this trial were about 2/3 partial responders versus a third complete responders, whereas about 50-50 in the NOVA trial. So a little bit poor prognosis group in the aerial 3 study. So the primary endpoint of this was an investigator-assessed PFS. in 3 analyzed groups in which they used an ordered step-down, multiple conversions, multiple comparisons procedure, where statistical significance was required in one group before moving on to the next nested group. And they looked at BRCA mutated, as you can see here, HRD, and then an all-comers intent to treat population. So the primary outcome of PFS was significantly longer with rucaparib in each of the 3 analyzed groups. The BRCA mutated HRD and intent to treat population, 16.6 versus 5.4, and BRCA mutated 13.6 versus 5.4 in the HRD group, and even 10.8 versus 5.4 in the intent to treat group. What differentiated Ariel 3 a little bit from the other PARP trials is the verification that rucaparib itself was an active agent. Not only was a response to platinum maintained in some patients, but also some of the patients with measurable disease had a continued response on treatment, and 20% achieved an overall response to the rucaparib treatment. So the trials are very similar, but there are subtle differences that I think it's important to take note of when comparing these 3/4 trials. Adverse event rates were similar to the other PARP trials, 54% of patients requiring a dose reduction and 13.4 patients discontinuing treatment.